Hello, everyone. A warm welcome. This is SM Abdullah, a member in Health Economics Research Network and fellow in ARC Foundation. I appreciate all your kind presence despite the busy schedule. On the capacity building front under the umbrella of HERN, this is the monthly webinar arranged by this network in collaboration with Center of Health Economics, University of York. Today, we have Sakshi Mohan, a research fellow at the Center of Health Economics, University of York, as our distinguished speaker. Besides, we also have the privilege to present Dr. Simon Walker from Center of Health Economics, University of York, UK. So Dr. Walker will share the role of Center of Health Economics in capacity development of young researchers under HERN. Followed by, we will invite our respected speaker. Sakshi will discuss how the linear constraint optimization approach can be used to design a health benefits package which maximizes population health given the health system constraint faced by a country. Her research has been focused on developing and applying economic evaluation methods to inform public health resource allocation, including health benefits package design and geographical resource allocation, with a particular focus on low and middle income countries. So without further ado, I would like to first invite Professor Simon Walker just to say a few opening remarks, and then I will request our speaker to present her presentation.
Thanks very much, Sam Abdullah. Hi everyone, I'm Simon Walker. I'm a Senior Research Fellow at the Centre for Health Economics at the University of York. And this webinar series has been organised in collaboration with colleagues from the ARC and the Health Economics Research Network, particularly Professor Umana and SM Abdullah. We are supporting this as part of our capacity development programme through the Diadem programme. And this is going to be the third webinar in the series, but we're hoping it's going to become a successful webinar series in providing capacity development in Bangladesh and more widely. As we noticed, we've had quite a lot of people from other countries who also wish to attend these seminars. So that's just a very quick introduction, and I'll pass over to my colleague Sakshi, who's going to present some work on health benefits packages.
Great, thanks Simon, and thanks SM Abdullah for inviting me. I'll just share my screen quickly. Great, so hopefully everyone can see this.
It's visible, please go ahead.
Perfect. So hi again, everyone. I'm Sakshi Mohan. I work as a research fellow at the Center for Health Economics at the University of York. And as Simon and Abdullah have already introduced, I'll be speaking about a piece of work demonstrating the application of the constraint optimization framework for health benefits package design. This methodology was used recently by the Ministries of Health of Uganda and Malawi as technical inputs into their service prioritization exercises. And the application to Uganda was also recently published in the Health Economics Journal with co-authors from Makerere University and the Ministry of Health Uganda. Two of my co-authors, Simon Walker and Paul Rebel, are both on the call as well. So my presentation will focus primarily on the outputs of this paper. So before I begin, I would just like to note that the work was produced under the Tanzi Research Program, which is a collaboration between researchers and policy partners across the UK, as well as member countries of the East, Central, and Southern African health community. And as part of the capacity building objectives of this research program, we've also set up the Global Health Economics Hub, which is a network of researchers and policymakers interested in topics related to epidemiology, health economics, and health financing. And it's a growing network with a growing library of learning resources. So if you're interested, I would encourage you to access this website to find out more. The link, I think the presentation will be shared with the participants at the end of the webinar. So with this brief introduction, let me begin by giving you an outline of my presentation. I'll start by providing some basic background on the policy context for this work, as well as provide you an overview of the state of the current literature. Under methods, I will cover the linear constraint optimization framework in detail, and then move on to results, which show you the outputs that informed the final package adopted by Uganda. And I'll conclude with some limitations which can further help inform directions for future research in this area. So as we're all aware, health systems of low and middle income countries are faced with several constraints. For instance, most have a per capita health expenditure of less than $50 per capita, not all of which is publicly funded. They're also faced with human resource shortages and infrastructure gaps. This means that aspiring to universal health coverage in an absolute sense is not only infeasible, but it's also not an efficient use of limited resources. So the WHO recommends that in order to progress towards universal health coverage in a sustainable manner, countries must first define essential health services and then try to scale up their coverage as well as reduce the out-of-pocket payments to access them before trying to deliver a fuller range of health services. So in the UHC cube that you see here on the right, this is represented by moving towards the left, so increasing coverage to the non-covered, and moving upwards, that's reducing the out-of-pocket payments in accessing these essential health services. So defining a health benefits package is essentially a step in this direction. Health benefits packages are explicit, positive, or negative lists of health interventions to be funded by public resources or other forms of pooled funding. One way to choose which interventions should be included in the health benefits package is simply to compare the incremental cost effectiveness ratio of interventions with the cost effectiveness threshold, which is relevant to the health system. So the incremental cost effectiveness ratio is just a ratio of the change in cost as a result of introducing an intervention divided by the change in health from delivering that intervention. And the change in health is often measured in terms of the disability adjusted life years averted as a result of the intervention. The cost effectiveness threshold can be interpreted as the opportunity cost of health expenditure. This is the improvement in health that would have been possible if the resources were used for alternative healthcare activities. So simply put, this is the amount of additional expenditure required to produce a unit of health at the margin or the marginal productivity of the health system. So the decision rule here is that if the ICER of an intervention I is less than the cost effectiveness threshold, then the intervention should be adopted, because this suggests that redirecting currently available resources from other health interventions to intervention I would result in a net health gain. So this figure from Okalek et al. 2018 demonstrates how this decision rule can be applied in a broader context. So this figure was used to guide the health benefits package design in Malawi. And what you see in this figure is a series of interventions. So each rectangle represents one intervention. The height of the rectangle represents the DALIs averted by an intervention for every $1,000 spent. And the width of each rectangle represents cost of delivering it to the population in need of the intervention. And the interventions are ordered from most cost effective to the least cost effective. So if we use the cost effectiveness threshold estimate of $61 per DALI averted for Malawi, which comes from a previous study, this method suggested that only the first 48 interventions in this list could be feasibly included in the health benefits package, simply on just grounds of resource use efficiency. Now, the problem with relying on just a cost effectiveness threshold to design a health benefits package is that by considering only an overall financial constraint on healthcare production, it implicitly assumes that resources are perfectly fungible. In reality, however, delivering health services requires a certain mix of health system inputs, some of which may be fixed in the short term. For instance, a system can't instantaneously convert resources that are locked up in specialized equipment into human resources. The constraint optimization framework here offers the possibility of accounting for multiple constraints simultaneously in solving resource allocation problems for the health sector. So what does a general linear constraint optimization problem or a linear programming problem look like when applied to a health sector resource allocation issue? So in the linear programming problem that you see on the slide, the decision variable is xi, and that represents the proportion of intervention I which is funded. The objective here is to maximize the value generated by a choice of xi's, which simply is the product of xi and the health benefit generated by delivering the intervention I to the population in need, which is represented here as VI. Constraints are the set of resources J, which are required to deliver the intervention. Final constraint at the bottom simply means that the chosen proportion of funding should be firstly non-negative and it should be less than 1. So this is the basic framework that we'll be applying in our approach that we adopted for Uganda. So this framework has been previously applied in answering different types of health resource allocation questions. So there are studies, for example, which try to optimize the distribution of a specific intervention amongst the eligible population. The last paper on this list, for example, tried to find out how the influenza vaccine should be distributed across the population in the US to achieve the maximum health gains. There's a second set of studies which tries to optimize the choice of interventions within a single disease area or program. For example, the 1984 paper by Bonham and Barlow tried to optimize the choice of interventions within the maternal health and child health programs. And then we have a final set of studies which try to optimize within an overall financial constraint facing the system. But we were not able to find any studies which account for both the financial constraint and physical resource input constraints in order to define the choice of interventions across disease programs. And this is what we've tried to do in our study. We also have extensions of this framework. So here, for example, the framework has been extended to account for investments into health system strengthening or horizontal interventions. So what happens here is that the objective function is updated to include Y, which is the expenditure on health system strengthening. And we assume that this scales the value of services delivered XIVI by a factor gamma, and the financial resource constraint here is just updated to accommodate this HSS expenditure. So instead of just having the cost CI of delivering XI, you also add Y, the expenditure on health system strengthening, to this, and this needs to be less than or equal to the total budget. So with this background, I will now proceed to describe our work applying the linear constraint optimization methodology to designing the health benefits package for Uganda. In the general case that we discussed before, the objective of our problem was to maximize the health benefit produced by a chosen set of interventions. And we defined health benefit as the net disability adjusted life years averted. So as you see in the equation in the red box, this is calculated as the incremental DALYs less the incremental cost divided by the cost effectiveness threshold represented by K here. The purpose of using net DALYs rather than total DALYs was twofold. First, this allows us to capture all the resource requirements for the interventions, many of which we could not capture in the constraint optimization framework due to data limitations. And second, because we only account for annual resource limits, this offered us a way to account for downstream cost consequences as captured in the cost effectiveness literature. In terms of constraints, we captured firstly the limit on the budget to purchase consumables, which is measured in USD. The second constraint was health workforce capacity across 5 different health worker cadres, namely doctors, nurses, pharmacists, nutrition officers, and mental health officers. And this was measured in minutes of patient-facing time available. Our choice set consisted of 125 interventions on which we had detailed information on cost effectiveness, consumables cost, and human resource time required to deliver these interventions. Now, following the general framework, we can represent this problem as represented by the set of equations on this slide. So as you see here, the resource constraints have essentially been split into 2. So you have the consumables budget constraint, which ensures that the amount of money that is spent to deliver the choice of interventions, to buy the consumables for the choice of interventions, is less than or equal to the total consumables budget B. The second constraint here applies to the 5 health worker cadres. And what we try to do is to make sure that the patient-facing time that is required to deliver the choice of interventions is less than or equal to the total patient-facing time available under each cadre. Because we're dealing with a large group of interventions, and some of these interventions were either substitutes of each other or sometimes needed to be delivered in conjunction with each other or were complements, we needed to account for 2 other constraints. So the first constraint here, which you see on the second line, is for substitutes. So it ensures that for each group of substitutable interventions, SK, the sum of people who receive each intervention is less than or equal to the maximum number of people in need of interventions in the group. So this just means that no individual would receive more than 1 among substitutable interventions. And the second one ensures that for each intervention A, which can only be provided after base intervention has been delivered, which is its compulsory complement, the number of people receiving intervention A is less than or equal to the number of people receiving the base intervention. And the rho factor here is just relevant for complementary intervention pairs where only a certain proportion of people receiving the base intervention are eligible for or are expected to meet intervention A. So for instance, we assume that only 5% of safe abortion cases would require post-abortion case management for complications. So we considered two main scenarios. The first one assumes that there is no task shifting between health worker cadres, which means that if the capacity of even one of the cadres required to deliver an intervention is exhausted, that intervention cannot be delivered. In the second scenario, we relax this assumption and we allow for task shifting. And more specifically, we allow for task shifting from pharmacists and nutrition officers, which seem to be binding constraints for Uganda, onto nurses. This means that nurses can take on the task of pharmacists and nutrition officers, and we assume a one-to-one transfer of time required because we didn't have better data available on the implications of task shifting. And finally, as an illustrative scenario, we also demonstrate the resource use implications of a health benefits package, which is formulated without accounting for health workforce constraints. In a separate analysis, we also demonstrate how this methodology can be used to guide investments into health system inputs. So we use the method to estimate the marginal value of health system inputs by rerunning the linear programming problem with an additional $1,000 invested into relaxing the constraints on the consumables budget and each of the health worker cadres. The analysis was performed using the LP Solve package on R, and if you're interested, the analysis script is freely available on this link. So moving on to the data sources, as you can imagine, applying this method can be quite data intensive. So we had to rely upon a range of data sources to parameterize the LPP framework. So to begin with, we needed estimates of the cost effectiveness of all the interventions being considered for inclusion in the health benefits package. And this came from a literature search, which included the Global Health Cost Effectiveness Analysis Registry maintained by the Center for Evaluation of Value and Risk in Health at the Tufts Medical Center, as well as papers published by the WHO Choice on cost effectiveness of interventions. And where these sources did not have the interventions we were looking for, we carried out a broader literature search on PubMed. For the size of the eligible population for interventions, we relied on the One Health tool, as well as the Global Burden of Disease study from 2017. For consumables costs, again, we refer to the One Health tool where feasible, and where the intervention wasn't available in the One Health tool, we also referred to the relevant cost effectiveness study. For health worker time required, we mainly relied upon the workforce optimization model exercise, which was carried out in Malawi in 2018, assuming that the health worker requirements in Malawi would be fairly similar to the requirements in Uganda. And so this study carried out time motion studies on health workers to estimate the number of minutes that would be required for different cadres to deliver a set of common interventions. And again, where data wasn't available through this data source, we also relied upon intervention input assumptions made for the One Health tool, as well as expert opinion from Uganda. For the health opportunity cost, or the cost effectiveness threshold, we referred to this paper by Lomas et al. From 2021, which gave us an estimate of $161 per DALI averted as the cost effectiveness threshold for Uganda in 2021. And finally, for limits on the consumables budget, as well as health worker capacity, we referred to Ministry of Health records from Uganda. So I'll now move on to the results. This table presents the output of running the LPP across our two main scenarios, without and with task shifting. Without task shifting, we see that only 45 interventions make it into the health benefits package. And these together avert about 26 million net DALIs. The least cost-effective intervention in the package has an ICER of $122 per DALI averted. If we look at the resource requirements, we see that while the capacity of pharmacists and nutrition officers is fully utilized, other resources remain underutilized in this scenario. And this is mainly because interventions cannot be delivered without a pharmacist dispensing drugs. We therefore consider the task shifting scenario on the right, which is closer to reality. So now we're allowing nurses to take on the task of drug dispensing from pharmacists, as well as the tasks of nutrition officers. So here we see that 73 interventions get included in the package, averting an additional 6 million net DALIs compared to the previous scenario, so a total of 32 million net DALIs. The ICER of the least cost-effective intervention remains the same here at $122 per DALI averted. In terms of resource use, we see that a better rate of utilization is possible through task shifting. We see the consumables budget gets fully used, and among health workers, we find that the nursing capacity, pharmaceutical staff capacity, and nutrition staff capacity is also at 100%. The mental health staff cadre remains underutilized mainly because of the high ICERs of the mental health interventions that we had under consideration. So these could not be included despite more mental health staff being available in the system. As an illustration, we also run the LPP assuming that there are no constraints on health workforce capacity. So in this case, the health benefits package is even bigger, 76 interventions included. However, if you look at the resource requirements for this, it becomes evident that this package will not be feasible to deliver because the health workforce requirements are much higher than what's available in Uganda. We can further disaggregate the optimal packages under the two main scenarios by disease program to understand what the composition looks like. So broadly, we see that under both cases, the majority of interventions are from within the reproductive, maternal, neonatal, and child health programs or the HIV program. In terms of additional number of interventions included when task shifting is allowed, we see the biggest implications for IMCI, nutrition, RMNCH, tuberculosis, and vaccine preventable diseases. And again, this is mainly because of relaxing the constraint on pharmacist time. We can also look at the distribution of resource use by program. This figure shows how health workforce capacity and the drug budget would be distributed across programs under the optimal scenario. Across the two scenarios, we see that RMNCH and NCDs command the largest proportions of doctor and nurse time. In the task shifting scenario, IMCI also comes up. Vaccines command a significant proportion of pharmacist time. Such an analysis can help inform both resource planning, but also understand where gains can be made in terms of improving the efficiency in the use of staff time. As I mentioned before, an important extension of this framework is to use it to assess the value of health system strengthening options. And this can be calculated by calculating the additional net DALYs by relaxing various constraints. So we see here that investing in nutrition officers and pharmacists offers the biggest bang for the buck in terms of expanding health system inputs. And this is true for both the without task shifting scenario and the with task shifting scenario. We can also invert these figures into the more commonly used ICERs. So just the inverse of these figures tells us that under the task shifting scenario, the cost of averting an additional net DALY is $58 for nutrition officers, $60 for pharmacists, $64 for nurses, and $100,000 for consumables. This gave us a very clear indication in Uganda that investing in health workforce capacity was a much wiser investment in the health system at present than investing in expanding the budget for consumables. Just as a comparison, we also found that these results are very context specific because different health systems have different bottlenecks. So we did run a similar analysis for Malawi. And if you look at the figure on the right, we see that doctors in Malawi represent the binding constraint on the system. So if we were to invest just $1,000 in expanding doctor capacity, this would result in 275 net DALYs averted. And again, inverting that figure, we find that the ICERs of doctors is as low as $3.6 per DALY averted. Moving on to the applications of this work. So as I mentioned before, this methodology has been applied to guide the design of the health benefits package in both Malawi and Uganda. It's also helped identify health system strengthening priorities in the two countries. In Uganda, for instance, the analysis reinforced the case for expanding pharmacist capacity. It's also been used to inform the Global Fund investment case on understanding the value of investing in human resources for health as they look to expand their coverage of HIV, malaria, and tuberculosis interventions. Finally, I'd like to note that the outputs of this analysis are not meant to be prescriptive, but they're just a tool in guiding decision-making as part of consultative processes. So of course, while the method allows us to account for resource use efficiency, there might be other objectives of the health system which are better accounted for through a consultative process. And you also need to account for the fact that not all the interventions can be represented within this framework, especially when data is scarce. So again, considerations for those interventions come from outside this analysis. So I'll now move on to some of the limitations of the work we did and also point out where the framework can still be used and expanded when better data becomes available. So firstly, the reliability of the analysis obviously depends on the reliability of the underlying data that we use. This has been specifically tricky with cost effectiveness evidence because we had to rely on a series of different papers to find evidence on each of the 125 interventions that we had included in our analysis. So for instance, in some cases, we had to rely upon cost effectiveness evidence from as early as 2005 because of a lack of better evidence available. So some of these results may be obsolete. We also had to make a constant returns to scale assumption. This means that we assume that the cost effectiveness of interventions would not change with levels of coverage. And this, of course, might not be true in reality because there are very often both economies of scale as well as diseconomies of scale. So again, within this framework, even though it is a linear constrained optimization framework, it is possible to account for this nonlinearity by simply disaggregating the interventions which have such a nonlinear relationship with scale up into segments. So it's possible to, for instance, have the same intervention broken down so that you have a different cost effectiveness figure for providing that intervention to the first 20% of the population, and another cost effectiveness figure for providing that intervention to the next 20% of the last 20% of the population. We also were not able to account for complementarity between interventions. Essentially, the framework assumes that all the interventions are independent of each other and their cost effectiveness, as well as the resource requirements for delivering the interventions, are just added up as more interventions are included in the package. As I mentioned, the exercise is quite data intensive, and this meant that where we could not find complete data on some of the interventions which the Ministry of Health wanted us to consider, we had to exclude them from the analysis. And that was close to 50% of the interventions. And notably, this was because cost effectiveness evidence was lacking for 3 programs. That's neglected tropical diseases, oral health, and eye, ear, and skin conditions. For such interventions, we recommend that a consultative process should be followed to decide whether these interventions should or should not be included in the health benefits package. Thirdly, we were only capturing resource requirements for 1 year. So the constraints that we applied on the consumables budget as well as health workforce capacity was applied only for 1 year, but we tried to address the issue of capturing long-term costs and consequences by using net DALYs rather than a total DALYs figure in the objective function. We also only included public health within the analysis. So all of our constraints were based on what's available in the public health system. This meant that we excluded the private sector or any out-of-pocket payments that expand the limits on the health system. And finally, we ignored the cost of transitioning from a health benefits package to another. So we sort of assume that we're starting from a blank slate and establishing a health benefits package, but it is possible that if this health benefits package that has been adopted is different from what was previously provided in Uganda, there might be additional costs to including new interventions or also excluding interventions that were available in the previous health benefits package. Now, some of these limitations can be addressed, and there are directions that future research can be expanded to address these. For instance, in our objective function, we only accounted for the net DALYs, so the health outcome, but it is possible to expand this framework to account for equity and financial risk protection as other objectives of the health system. Secondly, it's also feasible when data is available to incorporate other resource constraints. For example, medical equipment as well as inpatient bed capacity can act as binding constraints to the system, and it is very easy to add these constraints within the framework that we have shown. Thirdly, it's possible also to use the framework to evaluate system reorganization interventions, such as expanding the number of services provided by community health workers. So task shifting to community health workers, for example, would relax the constraints on in-facility health worker capacity, and this framework can be used to analyze the impact of that. Fourthly, we assume that the constraints were at the national level. This means that we assume that resources could be distributed in an optimal way across the country as needed. It is also feasible to capture the same constraints broken down by geography or level of care if that level of disaggregation is relevant to the country, because often it's not possible to move health workers or even move the consumable budget across geographical regions in the country. Finally, in order to overcome the challenge of not fully capturing complementarities between interventions as well as interdependencies between health system inputs, we could in the future use a full health systems model, which captures the interplay of health system capabilities, population behavior, and access and use of care. Tanzila Onse Health Systems Model for Malawi represents one such opportunity that we hope to use in the future. So I'll end my presentation here, and I'll be happy to receive any questions or feedback. Over to you, Simon. Or Abdullah, sorry.
Yeah, thank you, Sakshi. Thanks for such a nice and spontaneous presentation, and take us through step by step in your great work. Indeed, I would say that it's a very important contribution in the field of cost effectiveness and health economics field. You have covered almost all the points that was considered in your study. Ranging from developing your model, ranging from estimating the model and everything. So it was really, fascinating from my end listening to you, and I'm sure that it will be true for our audiences as well. And you have interestingly covered all the limitations and most importantly, the assumptions of the model that we always ponder upon as an economist, and also that pointed you through to the future research arena for this particular field. From my side, I will consider the great, the biggest take away message of this study is actually, as you said, that investing in a health system would be wiser than investing in health consumables from different perspectives. So thank you so much again for presenting and letting us know about your work. Now the floor is open, and I would like to request our audiences if they have any questions. So I haven't seen any yellow hand or any question in the chat yet. It seems that Sakshi, you were quite clear in your presentation and everything. That's great.
Yeah, I hope so. I hope it wasn't that I was too quick.
Yeah, no, it's fantastic. Just to break the ice, may I start with a simple question?
Yes, please go ahead, Abdullah.
Yeah. So, Sakshi, when you were, presenting the first slide of your result, you have shown the different scenarios considering the task shifting and without tasks shifting, how the changes have occurred, considering the health benefit packages and the outcome. So I was wondering why the in the task shifting scenario, why the doctors and clinical officers had a were lower underutilized or lower utilized under the task shifting scenario. Can you just shed some light on that?
Yeah, thanks for the question, Abdullah. That's a really good question. So like I mentioned, even in the task shifting scenario, the only assumption that we made was that the time that is required from pharmacists and nutrition officers can be transferred to nursing staff. And that meant that, once all of these cadres get utilized fully, there is still a binding constraint there in the system. And it appears that none of the other interventions in the list of 125 that we were considering can be delivered by a doctor alone. So once the other four resources here, the consumables budget, nursing staff, pharmaceutical staff, and nutrition staff gets fully utilized, then it's not feasible anymore to deliver more interventions only using doctor capacity, if that makes sense. And like I said, for mental health staff, this was mainly because the incremental cost effectiveness ratios of the interventions that we were looking at, and this included interventions such as treatment of bipolar disorder, treatment of acute psychotic disorder. All of these interventions had ICERs of higher than $161 per DALI averted, which is the cost effectiveness threshold for Uganda. So even if more mental health staff capacity was available in the system, because of the decision rule that we had, which is that the net DALI averted by the intervention still needs to be positive, these interventions did not make it into the package.
Is it also worth mentioning on the mental health interventions, but there was a significant lack of interventions even in the evidence base we were looking at, but it was one of the areas which doesn't seem to be particularly well captured in the economic evaluation databases, so it was difficult to inform. And therefore, it's not saying that these staff would necessarily be underused, it's just that they wouldn't come out of this optimization problem with interventions to give. But that's also why this is used to inform a sort of deliberative process where other factors are taken into play.
Thanks, Simon.
Yeah, thank you. Thanks both. And if you actually just want, being curious from my side, I hope that I'm not asking too many questions. So can you just go to the next slide? So like here, when you considered in the no HR constraint scenario for pharmaceutical staff and nutritional staff, can you just shed light why we can see such high overutilization for them?
Yeah, sure, Abdullah. I mean, firstly, feel free to ask as many questions as you'd like, because we still have 18 minutes left. So we're basically applying the same framework, but we've taken away the health workforce constraints completely. So essentially, you can ignore the last 5 rows when applying the framework alone. What the framework has done is that it's made sure that most cost-effective interventions get included in the package, but they remain within the total consumables budget available. So the consumables budget is exhausted here, and it's 100%. But then we just try to estimate, okay, for this package of 76 interventions, what are the health workforce requirements? Unsurprisingly, we haven't accounted for these health workforce constraints in coming up with this package. The requirements of pharmaceutical staff as well as nutrition staff is much higher. And again, we're not accounting for task shifting here. In any case, it wouldn't matter so much because the nursing staff also is getting almost fully utilized. These cadres being overutilized just represents the fact that particular understaffing amongst these cadres in Uganda. So if you wanted to include more interventions, it is important to expand the capacity on these cadres in order to deliver a bigger package.
Yeah, thank you, Sakshi. That answers all my queries. So,
well, I was just going to follow up on that one. I guess the issue here, Sakshi, as well, is that effectively shows the weakness of standard cost effectiveness rules. If we actually did focus on a sort of what historically has been done for health benefits packages, such as a league table approach, whereby you include all interventions which fall below that threshold value, you'd just be generating a package which is entirely unsustainable and potentially very damaging to health. Because they're just clearly, they did not have a staff to deal with, I think, all interventions where the ISA falls below what is the estimate of marginal productivity for Uganda.
Thank you, Simon. I think that made it a lot more clear to our audiences. We're still waiting for the question from the audience side. I am requesting our audiences if they have any particular queries to our speaker.
So the question is from Asiful, whether QALY has been calculated for the study. If so, which country value set has been used? As I mentioned, we were looking across 125 interventions, so we didn't actually carry out QALY or DALI calculations ourselves. What we did was instead to rely upon the current literature, providing us cost effectiveness estimates for this range of interventions. So the value set, which would have been used for different interventions, would depend on the country in which that cost effectiveness study was implemented. We tried as far as possible to prioritize studies that were coming either from Uganda or from the East African or Sub-Saharan African region, where there was cost effectiveness evidence available for these interventions from that region. But where that wasn't available, we also had to sometimes pull cost effectiveness evidence from other low and middle income countries. So again, the value set that was used would depend on the study, the region of the study, and the other assumptions made within that study. But we simply pulled that data from the literature rather than carrying out this analysis ourselves.
So I'm assuming if there's no further questions, we can probably bring this webinar to close.
Yeah, Simon, I also think so, because it's the kind of an pin drop silence, and I think Sakshi was quite clear in her illustration, and the whole process was clear to the audiences as well, and that's why we haven't got this much question. So Simon, would you like to make some concluding remarks on this?
Happy to quickly just say thanks everyone for attending, and thanks again to Simon and Rumana for organising, and Sakshi for presenting excellently. I thought it was very clear, although I was involved in the paper, so that makes it a bit easier for me. But yeah, just thanks again to everyone for attending, and we'll hopefully have another webinar next month or so. We'll circulate the dates.
Thank you so much, Simon, for joining, and thanks everyone for joining and making it a continuous success. So as Simon was saying, that it's a regular monthly process that we try to arrange under the umbrella of Health Economics Research Network, and probably we will come up with our next speaker and plan for the next month, and we will share the news from our side to you all as well. We would like to request our audiences to have a look on our HARN website as well for our regular activities and get the news of these, webinars and other, capacity building activities arranged by the Health Economics Research Network. We would like to thank Center of Health Economics, University of York, UK, for supporting us, and as well as we would like to thank, Diadem project for, supporting us from different other fronts as well. So with this, we would like to end here today, and we also would like to request our audiences to stay tuned with us for the future activities. Thank you so much for joining, and if you have any further questions or any other queries, please do email us. We will be in touch with you all. Thank you so much.